Good morning, everybody. I'm John Stelmach, and this is my grand rounds. So today I'm going to be talking about management of posteromedial meniscal root tears in middle-aged adults, scope debridement repair, and the role of UKA. So there's some pretty sexy topics, with regards to meniscal tears. This might not be one of them necessarily. But I'm going to be talking about a variety of meniscal tears that we see in sports office or general orthopedic office on a day-to-day basis that can be, pretty frustrating to treat. The objectives of this talk, we're going to have a case discussion, discuss posteromedial meniscal root tears in middle-aged adults and their natural history, discuss the treatment options for posteromedial meniscal root tears in this patient population, non-operative, arthroscopic debridement, meniscal root repairs, and the role of arthroplasty. To compare the treatments and discuss indications for each. So we'll start off with some cases. I have a little Nearpod link. If anyone still has the Nearpod app, I'll pull it up here. The code is ZJEV4. Oh yeah, that's because I'm pulling up the Nearpod. All right. ZJEV4. I'll write it on. There's no markers. So the first patient is a 59-year-old female who is complaining of medial knee pain, swelling, and weakness. The pain was gradual onset with no injury, really about 8 months prior. It's preventing her from walking prolonged distances. There's no locking, clicking, or instability. She's tried anti-inflammatories without any real relief. She's been doing home PT strengthening exercises. On physical exam, she has a negative McMurray, no pain. She has medial joint line tenderness, a normal knee range of motion, and a stable ligamentous exam. She has no past medical history. Her BMI is 29.6. These are her x-rays, AP and pseudolateral of the left knee. The knee looks pretty good. There's not really significant arthritis there, maybe a touch. These are the MRIs, which were then obtained. The MRI shows medial meniscal root tear functionally, with not really many degenerative changes. So, how would people, treat this patient? There's 4 options. There's only 4 options.
She was how old?
She was 59 years old. Pain, swelling, 8 months, intermittent, yeah. No, she had an injection a while ago, and she's been doing anti-inflammatories and home PT exercises. So I'm seeing a lot of non-operative modalities in this patient. Some people are saying root repair. Got an aggressive bunch.
Can you just repeat how the injury occurred?
There was no real mechanism, like it was a pretty, typical, just kind of woke up and it started hurting, maybe there was some minor trauma, but, it was never noted. So a little bit all over the board here. Some partial meniscectomy.
Have you seen it up there?
I don't really know. I would have to drag it. So that might take too long. So
and is there I guess I missed it. Other than pain, there are no instability complaints?
No, there's no instability. It's just, her main symptom is just kind of pain and, in some intermittent swelling in the knee. All right, so we'll move on to the next one. There's four. AS, she's a 54-year-old female, so with sudden onset left knee pain without injury, began 3 weeks ago. There was no, real mechanism. Again, it was just kind of, maybe some minor sort of trauma, but she can't pinpoint exactly what caused it. There's no locking or clicking, no previous history of pain in the knee. Pain is aggravated by daily activities, just going downstairs, squatting or kneeling. She's tried NSAIDs, but that's, just about it. And, that those didn't help. On exam, she has pain to medial McMurray, medial joint line tenderness, a stable ligamentous exam. She's neurovascularly intact. History of obstructive sleep apnea and a BMI of 28.2. So see how you would treat this one. I don't think so. No, I could pull it up on. Oh yeah, sorry. Films for her. So X-rays, maybe some, minor osteophyte medially on the tibia. Some maybe minimal questionable joint space narrowing, but it's not too bad. MRI was, then obtained. And her MRI shows, more meniscal extrusion, than the previous woman, and a posterior medial meniscal root tear. That's pretty split. Half people are saying non-operative modalities, and half the people are saying, they'd consider doing a root repair on this person.
Did you not say that the symptoms were for 3 weeks?
For 3 weeks, correct.
3 weeks with chronic findings on MRI. Is that right?
Correct. Yep, that's correct.
What are the residents putting this down, or the attendings?
Her symptoms began 3 weeks ago. And then she went and got an MRI. She did have chronic changes on that MRI, but many people that do have root tears have chronic changes. There's some studies that look at that, but we'll get into all that.
You're saying the extrusion of the meniscus is acute? In other words, 6 weeks ago and a year?
No, not necessarily. But this is how a lot of these patients present, just minor traumas.
I'm not disputing that, but you're telling us that with 3 weeks of symptoms and an MRI that looks like it's a few years old, because the meniscus is already extruded, people are fixing the meniscus. Attendings are writing that, or the residents are writing that in the answer?
On the near pot. Okay, I see. Okay. Yeah, that's those are residents. But all right, so another one, LD, 70-year-old female with right knee pain, onset 2 months ago. Again, no, major mechanism. She had cortisone injection when it occurred with minimal relief. She's been doing physical therapy. Symptoms are constant, and she has symptoms when at rest. On exam, she has pain with medial McMurray, medial joint line tenderness, stable ligamentous exam. She's neurovascularly intact. She has a history of obstructive sleep apnea, depression, hypertension, and asthma. Her BMI is 26.4. These are her x-rays, maybe some mild joint space narrowing, but, overall they look pretty good. And then, this is her MRI. So this MRI, shows a subchondral insufficiency fracture with a roughly 1.5 centimeter lesion on the medial femoral condyle, as well as medial meniscal root tear and some extrusion in a 70-year-old. So back to the Nearpod. So for this one, from attendings, I'm getting some arthroplasty, non-operative modalities mainly. The next one is a 59-year-old female who presents with complaints of left knee pain, reports that she was going for a run when she felt a pop in her left knee, and kind of got some pain that went down to her calf. She saw an outside physician who ordered an MRI. Today she has dull, achy, constant pain in her knee, notes some relief with NSAIDs. She has pain to medial McMurray, medial joint line tenderness, stable ligamentous exam. She's a healthy lady with a BMI of 25. She's an active runner. These are her x-rays, which show minimal to no arthritis. These were the MRIs that were obtained. Which show a meniscal root tear with some extrusion, as well as a chondral lesion on the medial femoral condyle. Back to the Nearpod.
So why did you tell everybody there's no arthritis? It looked like there was arthritis. The joint space was narrowed.
It's mildly narrowed on X-ray, and on the MRI, there's a medial meniscal root tear and there's an osteochondral lesion.
So that one had arthritis that a lot of the others didn't have.
I mean, the arthritis, if it is pretty mild. So a little bit of background. So first, we're going to start with a little bit of background on medial meniscal root tears, a little bit of the anatomy, mechanism of injury, epidemiology, natural history, and biomechanics. So meniscal root tears in the middle-aged, so to be classified as a meniscal root tear, there's got to be an avulsion or radial tear within a centimeter of the meniscal root. It leads to a loss of normal meniscal function of converting axial loads into transverse hoop stresses. Oftentimes in young athletic patients, it can be a traumatic etiology, but like our 4 patients before, it's more degenerative etiologies in middle-aged patients. The average age of presentation, 58 years old. In one study, risk factors are elevated BMI, female sex, decreased activity levels, varus alignment of the knee, and there's a significant risk of development for osteoarthritis in the future. So again, the presentation, chronic degenerative in middle-aged patients, squatting, minor movements, or no defined injury are often, how you'll see these present in the office. On physical exam, there's not really a specific and sensitive clinical diagnostic sign of medial meniscal posterior root tears in the literature. Some of the findings that you might see are pain with full extension, pain with deep flexion, joint line tenderness, positive McMurray test, palpable meniscus with varus stress in the extension if the meniscus extrudes is another possible finding. A little bit about meniscal anatomy. The meniscus is a formation of collagen fibers, proteoglycans, and glycoproteins oriented to allow the conversion of the axial loads into hoop stresses during knee extension and flexion. 50% 50 to 70% of the pressure is translated through either the medial or lateral meniscus Dissipation of the axial loads is necessary for function of the articular cartilage long-term. There's 4 meniscal root attachments, anterior, posterior, medial, and lateral. This presentation is mainly going to talk about the posterior medial meniscal root attachment. So this is just a little bit more about the anatomy. So the posterior medial meniscal root attachment is said to be posterior to the apex of the medial tibial plateau, lateral to the inflection point of the articular cartilage, and anteromedial to the PCL insertion. There's some measurements, which exist. The posterior root is approximately 9.6 millimeters posterior and 7 millimeters lateral to the apex of the medial tibial eminence. It's also described as being 3.5 millimeters lateral to the medial tibial plateau articular cartilage. This is an arthroscopic view of the posterior medial meniscal root attachment. You can see here the shiny white fibers, which are continuous with, but not the bulk of the structural attachment of the meniscal root, and they can be viewed arthroscopically. Radiographic assessment, oftentimes we get our standard x-rays, weight-bearing radiographs, AP, lateral, Rosenberg, and Merchant. In patients with continued symptoms, we often get MRIs, which can show meniscal extrusion greater than 3 millimeters past the outer edge of the tibial surface on coronal imaging, avulsions at the meniscal root on coronal T2, or radial tear within a centimeter of the root. Radial tears on axial imaging, or the ghost tear on sagittal, or ghost sign on sagittal imaging, which I have here on the right. So there's classification systems that exist, but functionally most of these are just radial tears within 9 millimeters to the root attachment. So what are the biomechanical consequences? There have been some studies that have looked at the contact pressure between the tibia and the femur after a root tear. In a 2009 study, Harner found that there was a 25% increase in contact pressures compared to a normal knee after root tear, found that posterior root tear was biomechanically equivalent to a total meniscectomy, and that repair of the root can lead to restoration of these contact pressures. This is data looking at different flexion extension angles from the paper, showing that inflection primarily is where the meniscus works to offload the tibiofemoral contact pressures. You can see at 30, 60, and 90 degrees of flexion, there is a significant difference of about 25% in terms of peak contact pressures. Posterior meniscal root tear is equivalent to total meniscectomy, and repairing the root can lead to restoration of meniscal function. So how does this physically work? Basically, axial loads on the femur and on the tibia attempt to extrude the meniscus laterally. The stiffness of the collagen fibers and tibial attachment allows the meniscus to absorb these hoop stresses and resist extrusion. This leads to less tibiofemoral stresses. When the meniscus is functioning normally, it can decrease the contact pressures, and when the meniscal root is torn, the meniscus can extrude and pressures can increase. Spontaneous osteonecrosis of the knee is a pathology that has been recognized for many years. It was thought to be an idiopathic condition that leads to development of osteonecrotic lesions, mainly in the medial femoral condyle, most commonly in middle-aged and elderly females. The precise etiology is still being studied, but much of the current literature has found a strong association between meniscal root tears and SONC. In 2019, study by Leprade found that 21 out of 26 recent studies implicated the meniscus as having an important role in the pathogenesis of SONC. He found that SONC term should be abandoned for SIFK because it's not believed to be related to ischemia-related osteonecrosis, as in some other pathologies, but more due to secondary to subchondral insufficiency fractures. In the 2000s, it was first described by Yamamoto that osteonecrosis was secondary to subchondral fracture. It's widely accepted now that SONC is kind of the end stage of this subchondral fracture and is part of the SIFK spectrum. So while not all patients with meniscal root tears develop SIFK or SONC, meniscal root tears are a risk factor for developing SIFK. A subset of patients will develop SIFK, and it's important to recognize so that you can kind of treat these patients appropriately and counsel them. So patients that do go on to SIFK have high rates of conversion to arthroplasty and surgical treatment in general. This is a 2020 retrospective review out of the Mayo Clinic on patients with SIFK as confirmed with MRI. It's looked at 223 patients with a mean age of 65 years old and found that mainly SIFK occurs medially, and when SIFK is present, 74% of the time there's a meniscal root tear or radial tear, which is functionally a root tear. 34% of patients progressed to surgery at 2.7 years. 30% of patients went on to arthroplasty at 3 years. At 5 years, the number were 47% going surgery and 37% undergoing arthroplasty. 40% of patients had 2 increases in KL level and KL level of 4 or more, or arthroplasty at final follow-up. So there's like a high risk of progressing to end-stage arthritis. In patients with kissing lesions of the medial femoral condyle and medial tibia, they're extremely likely to go on to needing arthroplasty. These charts show the data. Basically, patients start with mild arthritic changes to no arthritis, and after developing this condition, quickly will progress to higher grades of arthritis within 5 years and have high rates of arthroplasty. The relationship between degenerative medial meniscal root tears in middle age and arthritis remains cloudier than that of SIFK. There aren't really large prospective studies looking at the natural history of patients treated non-operatively for posterior medial meniscal root tear. Many of the studies on non-operative versus arthroscopic management of these tears give us some hints on the natural history. So studies that compare operative and non-operative modalities find similar numbers to patients with SIFK, like 34% progression at 10 years. There's a high risk of progression to arthritis and arthroplasty in the future for these patients with or without SIFK. So summarizing, posterior medial meniscal root tears in middle age often present after minimal trauma, such as bending, squatting, etc. No real defined etiology. Posterior medial meniscal root tears lead to loss of hoop stresses of the meniscus and 25% increase in tibiofemoral contact pressures. Posterior medial meniscal root tear are postulated to be one of the causes of SIFK/SLONC, which is a patient group that goes on to develop arthritis and high rates of conversion to arthroplasty. And patients with posterior medial meniscal root tears go on to arthritis and high rates of conversion to arthroplasty. So now,
John, sorry if I missed that. But can you make that connection that your patients with just a root tear, but who don't get insufficiency fracture?
Can't hear him very well.
Do they go on to arthritis and need knee replacement, or do they have to have the insufficient fracture?
yeah, so I made the connection a little bit. Basically there's a lot of studies that look at these patients being managed non-operatively, which I'll talk about shortly, as well as with posterior medial meniscectomy or partial medial meniscectomy. And, the patients in both of those cohorts have high rates of conversion to arthroplasty as well. So whether they're managed operatively with meniscectomy or non-operatively, they do go on to develop arthritis even without the insufficiency fractures. So now we basically have touched on the problem. So how can we best manage these patients? The options for treating this condition are really non-operative, arthroscopic debridement, root repair, and potentially arthroplasty if these patients progress. We'll start with non-operative management. The indications: pre-existing arthritis, unable to or unwilling to comply with post-op protocol, especially of root repair. Patients that are kind of poor surgical candidates, higher BMI, smokers, patients with medical comorbidities. So options for non-operative management are anti-inflammatories, corticosteroid injections, HA, PT, activity modification, medial unloader brace, weight loss, and reassurance that everything's going to be all right. So SIFK is another condition that's treated, pretty similarly. Protected weight bearing NSAIDs are things that we can try. Some people have looked into bisphosphonates, but found that these, don't really help. Some cases have looked at Forteo. There's much data that supports this. Additionally, some studies have looked at, if low bone mineral density is a cause, and there hasn't really been much of a strong connection between low bone mineral density and SIFK. So now that we've talked about the obvious first steps for a lot of patients, the next steps, oftentimes are consideration of, an arthroscopic procedure such as partial medial meniscectomy. So the indications for this are patients with continued symptoms and maybe mechanical symptoms after non-operative management, patients that are poor candidates for root repair, higher BMI, unwilling to cooperate with post-operative restrictions, root tears not amenable to repair, and patients, not really patients with significant arthritis, but maybe some mild arthritis. So this is a 2010 study in arthroscopy out of South Korea by Han and others, and they retrospectively reviewed 46 cases of complete posterior medial meniscal root tear with at least 5 years follow-up treated with arthroscopic posterior medial meniscectomy. The mean Lisholm score did improve at mean 78 months follow-up from 72 to 77, which is pretty minimal and isn't clinically impactful. But 35 progressed at 5 years from KL grade 0 to 2 to 2 to 4, which is a pretty high progression of arthritis. 56% did have an improvement in pain, and there was a 67% satisfaction rate, which is kind of interesting that that's higher than the rate of people that have an improvement of their pain. This is a study by Critch and others in 2017 out of the Mayo Clinic that I kind of referenced earlier when I was talking about the outcomes of these patients managed non-operatively. Clinical and radiographic outcomes were compared between non-op and patients that underwent posterior medial meniscectomy at minimum of 2 years follow-up. There were 52 patients, 26 in each group, 54% of the patients in the meniscectomy group and 34.6 in the non-op group progressed to arthroplasty at a mean of 54.3 and 30.2 months. Arthritis progression was 36% to 91.3% in the operative group. There wasn't a statistically significant difference between the groups in outcome scores, arthritis or progression to TKA. And they concluded that partial meniscectomy for complete medial meniscal posterior root tear provides no real benefit in halting the arthritic progression, and patients who undergo posterior medial meniscectomy for medial meniscal posterior root tears still progress to arthritis at a significant rate, and they have poor clinical outcomes and a high arthroplasty rate at over 5 years follow-up. So overall, there's a high rate of progression to arthritis and arthroplasty in these patients, whether they are treated non-operatively or with meniscectomy. Meniscectomy may provide temporary symptomatic relief for a subset of patients that fail non-operative management or are not good candidates for root repair, or those that don't have tears amenable to repair. Patients that are older, have higher BMI, varus knees, pre-existing arthritis, or increased risk of progression to arthroplasty. So next we'll talk about root repair, which is something that, is more indicated in patients that are good surgical candidates, age less than 50, active, no grade 3 or 4 outer bridge cartilage changes, no joint space narrowing, and no joint malalignment. So there's multiple techniques for root repair. There's a transtibial pullout method, the suture anchor method. It requires pretty extensive postoperative rehabilitation, which is why, most people are pretty hesitant to go this route in their middle age or older age. But it is the ideal treatment for preserving the long-term integrity of the knee joint. So technique, you have the suture anchor technique where suture anchors are placed through the posterior medial portal. It's kind of technically demanding. The meniscal root is then tied to the anchors. The transtibial pull-out technique, sutures are passed through the meniscal root and passed through a tibial tunnel and fixed with the suture button. In 2013 showed that fiber tape and fiber wire had the highest slope to failure, as well as stiffness when comparing to PDS and Ethibond. Also studied different suture techniques, which showed that when comparing modified Mason Allen, which is a horizontal mattress and vertical simple stitch combined into a cross-like pattern, horizontal mattress, 2 simple sutures, and some other novel techniques, that modified Mason Allen and simple stitches had the highest stiffness and load to failure. There's minimal clinical studies comparing these, but one from 2014 out of Japan showed that there was no clinical difference in outcome scores, extrusion and arthrosis, but significantly better restoration of extrusion with modified Mason Allen. Rehabilitation wise, this is kind of where this treatment becomes difficult in a lot of these patients. Oftentimes, patients have to be either non-weight bearing or toe touch weight bearing for 6 to 8 weeks. A lot of the people I talk to say, about 6 weeks is how long they keep them non-weight bearing. They're to avoid, greater than 90 degrees of flexion post-operatively, depending on the protocol. And the return to play is like 4 to 6 months, which, for a runner or someone may be relevant. This is a meta-analysis of 324 patients in 13 studies with a mean age of 54 years old, 62 that underwent root repair. 62% demonstrated complete healing at follow-up with MRI or second look. 32% demonstrated incomplete healing, loosening of the contract or excess scar tissue, and 5% demonstrated a complete failure at 33 months follow-up. But there was a big improvement in outcome scores. This is a 2015 case series that looked at 51 patients who underwent pull-out repair for posterior medial meniscal root tear at 31 months follow-up. Patients who had worse clinical outcomes were those that had outer bridge 3 or 4 changes and, greater than 5 degrees of varus. Even though, the patients did well, the meniscal extrusion did progress from 3.6 to 5 millimeters. So these are kind of their outcomes, looking at the overall patients, and then kind of looking at the patients that have, pre-op, varus malalignment and degenerative changes. So you can see the patients with the malalignment and the degenerative changes do significantly worse. This is a prospective case control study of 45 patients that were a little bit younger. There was significant improvements in outcome measures and pain scores at 2 years. Patients that were older than 50 were found to do a little bit worse. BMI wasn't really associated with worse scores in this study. And then, finally, this is another study, pretty recent, out of the Mayo Clinic. They kind of looked at 45 patients with posterior medial meniscal root tears, which were matched based on age and KL grade at a mean 74 months follow-up. And they found that out of the 15 non-op patients, 4 progressed to arthroplasty. Out of the partial meniscectomy patients, 9 progressed to arthroplasty. And out of the 15 root repair patients, none progressed to arthroplasty. They also, looked at the x-rays at follow-up and found that the root repair patients had lower rates of progression to arthritis. Obviously in a paper like this, the results are subject to selection bias, because there were obviously other factors like BMI, which were not really controlled for, smoking status, activity level, motivation to undergo root repair, that would make this cohort less likely to progress to arthroplasty. But that said, ultimately, the results are compelling, with less risk of arthritis progression in the root repair group. These are, the numbers for survival to arthroplasty in each of the 3 groups, as well as the progression to arthritis. You can see the non-op and the partial meniscectomy group both progressed, over 1 KL level over their follow-up period. This is another 2019 systematic review of the literature, which looked at 355 patients, 229 root repairs at mean follow-up of 40 months. They use the model to project strategy-specific costs in 55-year-old patients with meniscal root tears and no arthritis. Over 10 years, repair, meniscectomy, and non-op led to 53, 99, and 95% rates of OA, and 34, 52, and 46% rates of arthroplasty. The 10-year costs were the lowest for the root repair group, and the quality of life for all the patients were similar. This is kind of what they found for their freedom from total knee replacements in each of the group. So in general, meniscal root repairs are the best option for patients that have minimal arthritis, with good surgical candidates who wish to preserve their knee long-term and are willing to tolerate the post-op protocols, which is kind of the most important part. Studies are promising and show that patients get improvement in outcome measures and lower rates of arthroplasty. It can be cost-effective to pursue this, because you can potentially avoid some arthroplasty. Patients that wish to undergo root repair should be counseled about the post-operative rehabilitation beforehand, because it's a big commitment to undergo in a patient population that's often not that active and wants to get back to work. So the role of arthroplasty, basically indications would be medial meniscal root tear in the presence of isolated medial compartment bone-on-bone arthritis, because there's some studies that show worse outcomes in partial thickness arthritis. SIFK after medial meniscal root tear, which fails conservative modalities and goes on to osteonecrosis. There's no clinical or radiographic improvements after 2 months of non-surgical treatment, or there's a large osteonecrotic lesion of greater than 3.5 centimeters, or greater than 50% of the condyle with collapse or not amenable to joint preserving procedures. I think the other big question that remains, which I'll show, is that there's that low-grade medial compartment OA in the presence of these root tears. It's not really something that's been studied. This is a retrospective review of 94 consecutive uni patients with partial thickness cartilage loss, comparing them to full thickness loss, functional outcomes, reoperation implants were judged in the patients. Knees with partial thickness loss had worse outcomes at 1, 2, and 5 years postoperatively compared to those with full thickness loss. A quarter had fair poor outcomes. A fifth failed to have improvement in OKS from baseline of 4 points or more, which is double seen in knees with full thickness cartilage loss. And the rates of reoperation were much higher, 3 times higher in patients with partial thickness loss, mostly arthroscopy for continued pain. This is a retrospective review of 21 patients who underwent uni for isolated medial compartment arthritis following posterior root tear. Their indications were radiographic diagnosis of isolated medial compartment OA with KL grade ranging from 2 with high grade SIFK to 4 not necessarily with SIFK. Time from injury to surgery was 195 days. Clinical outcome measures improved and VAS decreased. There wasn't any aseptic loosening or deep infections. You can see that their outcome measures increased greatly postoperatively in these patients. And this is another study, looking at SONC in general, and it's a retrospective study out of Sweden in 2006 comparing 29 knees with SONC who underwent uni to patients with primary osteoarthritis who underwent uni. All underwent Oxford, no implants failed in either group, and the mean Oxford score was pretty similar between the SONC group and the OA group. So in general, uni is like a good option for patients that have root tears and have failed conservative modalities, or have SIFK or SONC with at least KL grade 2 changes, have bone-on-bone medial compartment arthritis, secondary to root tear. There's no real good literature guidance for patients that have posterior medial meniscal root tears and mild arthritis / partial thickness cartilage loss in the absence of SIFK and SONC. So, this is kind of like a treatment algorithm of how I would treat these patients if they came into the office. And the patients that have minimal DJD and are good surgical candidates, it's probably the right move to discuss root repair. Some of them may ultimately, decide that they don't want to undergo the commitment, and those patients, you would consider non-operative modalities. In patients that do, root repair is probably the best option for preserving the long-term integrity of the knee. In poor surgical candidates, you just always start with non-operative modalities. You can consider a posterior medial meniscectomy, but you again have to counsel those patients that there are some studies that show that this can, increase the arthritis progression, but the studies did also show improvements of pain, and that there was a satisfaction rate of 67%. And after that, it's basically arthroplasty when the patients become candidates. In patients that already have DJD, you can try non-operative modalities, and then, ultimately they'll be candidates for arthroplasty. So some limitations are that there's not really great literature on the natural history, not really prospective studies. It's mainly kind of retrospective studies of patients that were treated, and they're all pretty small because, it's difficult getting the numbers. There's not really literature that looks at outcomes of uni or arthroplasty in general for patients with these root tears and mild to moderate OA or partial thickness cartilage loss in the absence of SIFK or SONC. So, I think the question still remains, how long do we have to exhaust non-operative treatment modalities before these patients go on to arthroplasty? Do they have to be true bone-on-bone arthritis before, they'll have good outcomes? So back to the cases. The first case is RG. She was followed for kind of 4 years. She was managed conservatively with injections, did well for 4 years, and then ultimately developed a contralateral hip labral tear, which caused her to put more weight on her left knee, and she developed worsening of her knee symptoms. So now she's attempting a course of HA injections. You can see, her follow-up x-rays, her arthritis has definitely worsened a bit. More osteophytes, more joint space narrowing.
What would you do if she done it do well with HA injection.
If she fails HA injections long-term, I think uni's a decent option, depending on how bad her symptoms are. You just have to, make sure she's a good candidate for uni, so consider getting lateral stress x-rays and, make sure that the patellofemoral joint looks okay. And she doesn't have pain laterally.
Not small person.
No, her BMI was it was under 30. Yeah, it does look big. She must be all in the thighs. Or it was an optimistic weight. I'm not sure. She works on case 2. There were 5-year follow-ups on her. She initially underwent cortisone injections, got several months of relief, developed some painful clicking. It was planned that she undergo diagnostic arthroscopy with root repair or meniscectomy, depending on the characteristics of the tear. She did undergo partial medial meniscectomy in 2019 because the root tear was difficult to repair, and she had some DJD, to my understanding. And she did well for a few years, and then started to have re-aggravation of her symptoms a few years later. She started HA injections. She's had persistent symptoms and limited relief from those injections. And, you can see her arthritis progressed a bit. So
how many years?
This was 5 years. This is 5 years. Next case had 5 months of follow-up. She initially got non-op therapy with cortisone injections, medial and loader brace, HA injections, and PT. She's had continued pain and discomfort throughout this period, but she has a planned trip overseas in 6 months, and it's just going to keep trying cortisone injections until she can't tolerate it anymore, and then would be probably a candidate for arthroplasty. Case 4 is the runner. She was a little bit older, but she's an active runner, and her tear was more acutely associated with running. So she was taken to the OR for root repair. It was found arthroscopically that she did have a large chondral lesion of the medial femoral condyle. So she underwent microfracture for that. You can see the root tear here on the top right, and then she underwent root repair and microfracture. She's doing well so far. She's about 1.5 years follow-up. Conclusions: posterior medial meniscal root tears in middle-aged patients are like complicated problem. There's often not like a satisfying treatment that can fix these people expeditiously. Management has to take into account degree of associated pathology, patient activity level, health, BMI, and patient goals. And it's important to have shared decision making when choosing a surgical treatment, because there's such a difference in possible outcomes and postoperative rehabilitation that the patient really has to be on board if they want to consider root repair. These are the citations. And thanks, and open for questions.
Nice talk, John. I got a question. Is there a technique or a device that's come out for root repair that is the preferred method of management now, or is there still controversy in the best way to fix it?
No, most people are doing transtibial pull-out method for root repair because it's technically not as challenging, and they have pretty good outcome measures, and they're using these either simple stitches, 2 simple stitches, or modified Mason-Allen stitches, which have been studied and shown to have pretty good outcomes.
I have a couple of questions.
Hang on a second, I can extend on that a little bit to Letty. In the past 10 years, some equipment has come out that it guides so you can drill a tunnel to the back of the tibia, specific for root repairs. A smaller suture passer, the mini first pass, is one of them with the other to get around the tibial spine and put your kidneys in the root. And then more recently, I've been using a lateral row type anchor instead of a button on the tibia, so you can get more traction as you're fixing it. I've been happy with that. Having said all that, these can be challenging because oftentimes it's a tight knee. Getting into that spot is not easy.
Hey, John, it sounds like somebody with a very small squeaky voice is talking, but I can't really hear him. Can we get a better mic on, or?
Do we have another mic for Dr. Swan? He is a loud booming voice, but it must be the mic.
Is that better, Timothy? Do I need to repeat all that? Yeah.
I think so.
So there are new devices that allow you to get to the back knee better shoot capacity, better angle guide, things that didn't exist that recently less than 10 years ago. The suture anchor, a lateral row anchor on the tibia allows for better traction on the stitches when maybe then a button. That's another option.
John, I thank you for your review. Unfortunately, this is my life. I see every one of your scenarios every day of the week. And the difficulty is knowing how to, whether you can achieve good outcome. But I can tell you the ones that don't do well, the ones in an extruded meniscus do poorly, and the ones with fractures of insufficiency, which is probably 15 to 20% of the ones I see, also do poorly. The unloader brace works for a while. The acute pain goes away, but left with chronic pain. I have referred a few of the operative candidates to KG to try to do repairs. I don't know what they've done, but he's done a bunch. We really don't have a good solution for this age group and injury.
Yeah, that's interesting. It's a question that I'd asked some people about the prevalence of SIFK in patients with root tear, and it's interesting. 15-20% is kind of your experience. There's not really a good number in literature that I found at all that kind of demonstrated that, but that's interesting.
This is one of the reasons I get an early MRI, because if you see the insufficiency fracture, you can put them in the brace, and it's usually people that have had some mild symptoms and then acute exacerbation, and that's probably when the insufficiency fracture occurs. So it's good knowledge to know, and then you can put them in a brace. Some people don't wear it, and eventually the acute pain from the stress fracture goes away, but they're left with a chronic problem.
Clinical history standpoint, with a typical degenerative meniscal tear, I do think most of those occur without any trauma at all. But in this subset of patients, oftentimes I'll find it's going to be accident history. If you remember one particular event, it's usually something very simple, like getting up out of a chair and they feel like a pop in the back of their knee, and suddenly their knee's more painful than it's been. They had some pain in the past. We kind of didn't really pay much attention to it. So when I hear that history, it does kind of perk up my ears a little bit, and probably more aggressive in getting an MRI to see if they have a root tear. I think they're a good surgical candidate.
Totally agree.
KP agrees, by the way. Yeah. John, I have a question for you. In your review, obviously meniscal extrusion is something we talk about with meniscal allografts and their success rate, and now it's become a big part of meniscal root repair, especially dealing with younger patients. But have the repair techniques actually reverse these extrusion? Or do the outcomes correlate with the amount of extrusion after surgery?
So the one study that I looked at showed that regardless the meniscal extrusion progressed, and I didn't find any studies that looked at the correlation without outcomes on that, but that would be something to look into.
That's the challenging part of the procedure, and why when you're dealing with 55-year-old semi-overweight women, because that's what they all are. You look at the MRI and you have a little meniscal extrusion, and you try to fix it, and we're not doing it. Look at the current data that's presented, the academy of posters and things like that. Our repair techniques don't really do a great job in preventing extrusion going forward, so. There's been talk about centralization stitch, which is, they're trying to actually not, and now there's more attention being paid to maybe reconstructing, and Aaron Chris writes about this because he's been in a root repair research about reconstructing the meniscal tibial ligaments to try to prevent meniscal extrusion. So maybe even getting to the point then where people are talking about putting small anchors on the very rim of the tibia and trying to hold the meniscus into the joint. And maybe just a pull-out suture that we use, that you showed in the technique, or the suture anchor technique doesn't pull the meniscus back, but doesn't really hold it enough to. With meniscal allograft, they talk about 3 millimeter extrusion being a barrier. It's probably the best guess here.
Yeah, John, I thought that was a great talk. So sorry, Charlie, I couldn't really hear most of what you said. So if I say something that overlaps or that you already said, I apologize. But I just want to have a couple of make a couple of comments. First of all, I think that it was a great talk, and these are a little bit challenging in terms of treatment. But I think the way I would look at it and have looked at it is a little bit different than your papers, and that you stressed. And I'm surprised as a potential joint replacement person going into this, you you didn't actually accept this. The most of these things are focused on preventing, arthritis, which, clearly in a younger person is the goal. But in the middle-aged person, I mean, you really want to relieve their pain. So early on, it's reasonable, no matter what their MRI or X-ray findings, it's reasonable to do conservative treatment if they only have symptoms for 3 weeks, like Dave Kirschenbaum was alluding to. So pain relief, conservative measures for the first few months, and then then you want to get them out of pain. If they're 59 years old and they have kids, they have a job or whatever, to go through a meniscal repair, which is to me a dubious outcome. I mean, again, the literature may be mixed on it, but what's your goal? Your goal is to get them out of pain, not to prevent arthritis. I mean, if it goes on to arthritis and they're out of pain for 5 years, man, that's a win-win. That's the sports guys get a a time at the trough, and so do the joint guys. The main thing is to keep these people, functional and out of pain. So if a meniscectomy early on, can get them out of pain, and then they go on to progress, okay, that's, it's not ideal, but it's reasonable, and then they're out of pain again when they get their unicompartmental knee replacement or whatever it is. And the other thing about the uni data, I would say, is a lot of times when things don't really make sense in the literature, it's because there's a lack of stratification of the subjects. So there was just a paper a couple of years ago that stratified patients based upon they're taking a psychological index test, and so about a third of them scored pretty highly on the depression levels. And of those people, they divided up, and it was a randomized study. They divided up into 2 groups. One they gave Cymbalta to, and the other ones they didn't. And it turns out the Cymbalta group did like way better. Like it wasn't even close. So I think when you have a group of people who don't have a lot of arthritis and you throw them in, I mean, a lot of those are contaminated by people who have other issues. I think for someone in this group, if you have a uni or a total knee replacement, and they actually have legitimate reason to have pain, I think they'll do just fine. So I mean, it's a little bit confusing, but I think it's a little bit of a tough sell to have a 59-year-old have a root repair when they didn't really even have an injury in the first place. So what makes you think, they're going to do well and with the quality of their meniscus in the long run? Whereas a meniscectomy will get them out of pain, and you do the arthroplasty later. I don't think there's anything wrong with that.
Dave, I don't know if you can hear me, but I don't think that's true. I think doing the meniscectomy on these patients does not help.
Well, again, I think if you stratify those people, if the person has significant, issues with their early chondromalacia or early arthritis, then yeah, then I'm okay to think about doing a partial knee replacement. If they don't, and they're having mechanical symptoms, then, and John's just cited a study that shows that they did do better. So, I mean, I'm not saying all of them need meniscectomies, but it's not an unreasonable thing to do, at least as an early option, knowing that you're not doing it to prevent arthritis in the long run. You're doing it to get them out of pain. So whether you do a meniscectomy or not is really, that's a different issue.
To just expand on that one step further, I don't know, maybe you could answer it, but everyone that has sunk and has edema in their bone, at least I see the older people. If they have edema in their bone, no matter what you do to the meniscus, that edema may not go away. And people have sunk with no problem with their meniscus, and the best you can do is maybe 6 months of unloading it, and that sunk may go away. So I guess the question is, when we do root repairs, which makes sense in younger people, as Dave alluded to, if you're doing it in an older person, are you doing it in people that have edema in their femur? One, and two, once the meniscus is extruded, it's been around and torn for a really long time. Are we expecting an extruded meniscus ever to heal?
I'm not sure that there's like, I didn't find any clear literature or come across any on how quickly the meniscus takes to extrude necessarily. So I'm not entirely sure. Our one patient that I showed, had an injury a few weeks ago and her meniscus had already extruded. So I don't know. And
well, if you're calling that an injury, what was the injury?
it just occurred while running.
Right. So there was no injury. She was just running. Who tears a meniscus just running? So there was a problem with the meniscus, and then something like people have extruded meniscuses all the time. You see the MRIs as an extruded meniscus, but they're not all symptomatic. And the question is, at what point is that? It's like cuff tear arthropathy. People come to your office with a high riding humerus and a chronic rotator cuff tear for 10 years, and all of a sudden it hurts. Some minor thing. They lifted a piece of paper and it hurts. And I think that's what I think people have to separate that out, so what you're doing. And I don't know that it's separated out. And so if you don't separate out people who have sunk and people who have extruded meniscuses, which are chronic, it's rare that someone has an acute twisting injury and comes to you with the meniscus extruded. The majority of the time, it's not extruded. I mean, look at the younger people. I mean, I don't operate on them, but I see them with root tears. Acutely torn, it doesn't come to you extruded.
Okay, the young people we agree that's different group. They are.
We're having a hard time hearing the people that are talking
Is that
there.
any better? We'll try another one. That one any better?
Hey, John, you just repeat-
Yeah, I'll just repeat what Dr. Gatt has to say.
Is that any better?
No, we still didn't hear anything.
Oh, that was much better. You start saying them. Was that you, Sean?
Yeah, that was me.
Yeah, that's great. We can hear you. Fine.
So, Dave, obviously the young people, the young patients are a different population. They occur with ligament injuries. It's very uncommon to see an isolated root tear in like a high school or college athlete. It's almost always in conjunction with a ACL tear or PCL tear or something like that. But I mean, the ones that we see, you definitely see the acute onset of these root tears in the middle-aged patient, but it's not a twist. Like I said, it's really a relatively trivial. If you want to call it a trauma, you can call it a trauma, but getting up out of a chair and feeling a pop in your knee, and then your knee's like acutely painful, that's probably the time when the root finally gives way. It's definitely degenerating over time, because it's not like it just tears. It's kind of something that's wearing out and then gives way. John pointed out the shiny white fibers, which is the ligament that connects the meniscus to the tibia. That's really I call it the root ligament. That's what tears most of the time. But again, when you get in, you don't even see the ligament. You just see the meniscus free floating in the back of the knee. So I mean, I think you can get to them early before they extrude if you have a high index of suspicion. But again, the same question is, in a 55-year-old person who has to go to work, do you really want to put them on crutches for 6 to 8 weeks? And for Dave Harwood, I'll say, like, I can tell you that I've referred these patients to you and Steve and Will, like, because I unfortunately see a lot of them and I don't know what the right answer is for them. I don't have any idea right now. And oftentimes you guys say, well, yeah, you have arthritis, but it's not that bad, so we don't really want to do uni yet. And then I'm stuck, like, struggling with these people because I give them HA shots and I put them on loader brace. And essentially, I think what we're doing is treating them with benign neglect until their knee gets bad enough that then you feel that they're a good candidate for a uni. But I mean, that could be like 2 or 3 or 4 years of managing the patients. I think John's second case, in fact, is a perfect example. I think it's my case. And I just when I do a meniscectomy, it's a very minimal meniscectomy. But you know, she's done okay, but 5 years later, she's ready for a uni. Was it worth it? Like, doing all that stuff, or should we have just done a uni 5 years ago? I don't know. The joint guys seem to see, if the symptoms aren't really bad, you seem somewhat reluctant to proceed with the joint replacement. And I think, to John's point, if the symptoms aren't terrible, then the outcomes aren't as good. And I mean, I don't know. It's a tough sell. I think you are trying to figure out what you're going to do with, once you buy into this, you're probably managing a patient for anywhere from 3 to 5 years before they actually get the definitive treatment, which is going to be a uni.
Right, but Charlie, when you see this acute tear of the root, do they come to you acutely with the meniscus extruded?
No, that's what I'm saying. If they come in with that history, the meniscus usually isn't extruded a lot of times.
All right, so but those are the
It
ones
can
that
be, but not always.
right, but those are the ones that, if you wanted to study the group, those are the ones that might heal and do well. But what we saw in those 4 cases, a couple where it was extruded, and the option of repairing that, I mean, if you compared repairing an extruded one to the ones you're talking about, you're going to get different results.
Well, that's why they're working on newer techniques with centralization stitches and meniscotibial ligament reconstructions or repairs. So people are trying to fix the extrusion at the same time. And even again, not talking about younger patients, but the data isn't definitive yet, but even the current 2 techniques that John showed don't necessarily prevent progression to extrusion later on. They lead to better outcomes and a longer time to knee replacement, but they don't, if you look at some objective data, which is primarily people seem to pay the most attention to extrusion, it doesn't really seem to prevent it.
Couple of comments. If you find that someone is not an operative candidate, like Charlie said, this is painful for Dr. Butler, Charlie, and I. We see this a lot, and it's, what do you do with these people? Some of them are very, very uncomfortable. They're very unhappy, and they want relief. And we try everything. And I do find those that are willing to unload it with a cane, or willing to back off for whatever they're trying to do, some of them do get better, just not up, and you just got to nurse them along for several months, and they do get better, and the edema or the stress reaction gets better. So that's just one point. But I posed 2 questions. One that I don't think we have the answer to. One is, oftentimes we give these people a cortisone injection. Should we not be doing that if they're potentially a repair candidate? Because it's already compromised tissue, like a rotator cuff. Should we not be doing that if we think we might repair them? The other question or comment I have is, we're reluctant to fix these because they got to be non-weight bearing for 6 weeks, which is tough, middle-aged person working. But what if you broke your ankle? If you break your meniscus, you're non-weight bearing for 6 weeks. If you think of it that way, and if it works, then maybe it's worth doing.
True. Yeah, I think that the main, like, crux of the issue is, like, a lot of these people are not getting better with conservative modalities, and it's just kind of, their long-term getting HA shots and not satisfied with their knee, should we be pulling the trigger earlier with like uni? Because, it can get these patients relief with, a more minor procedure that's, more bone sparing and can be easily revised in the future if it fails, but it has good outcomes. So.
Well, one last thing that I think, and certainly in the United States, we don't pay a lot of attention to is alignment. And if you do have a patient that decide you're going to do a root repair on, it probably is worth getting full length standing films and considering, osteotomy if they're in a decent amount of varus. I saw this really cool case at the academy where it was a, like same typical like middle-aged patient, but had the root repair and varus. And they used the template guided osteotomy. So they put the guide on the tibia to make the osteotomy cut. These are small corrections, like maybe like 4 or 5 degrees. But then the guide actually had a drill guide for the root tunnel, and the tunnel came out exactly at the root attachment site. It was like perfect. So no messing around with, trying to slip something through the notch in a tight spot. You just put this guide on and the pin came out right at the root attachment site, which was very cool.
Since I had a root repair on Tuesday, unfortunately, at one of the outside hospitals. A guy, 47, a little bit overweight, had some pre-existing knee pain for a few weeks, saw a different doc. They scanned him. He had a little bit of a meniscus problem at the root, but not really what was considered a full tear. 2 weeks later, he felt a pop, and then he came to me, and I managed to get insurance to do another MRI, and he definitely completed his root tear, and he was otherwise had a healthy knee. So it's probably a good example of how it's an acute on chronic situation sometimes. No, it was not extruded. And I fixed it, and it was very challenging. But one other thing is you often have to pie crust the MCL to get back there, and that still doesn't always help.
Thanks.